So cancer surgeon does cancer surgeries. That's the obvious part, but it starts much before cancer surgery. So a cancer surgeon, like any other oncologist, any other person working in the field of cancer, starts with seeing the patient. And cancer surgeons see the bulk of the patients who think they have cancer or who've been diagnosed with cancers, especially solid tumors. So when a patient comes to us, what we do is we try to find out whether they have a disease, what disease they have, and how much it has spread, what all parts of the body does the disease exist in. So what is the disease is diagnosis, which generally in a cancer setting involves taking a biopsy of some sort, and that gives us an idea of what disease we are dealing with. Then we come to the aspect of where it has spread, which is what uh, generally people ask is what is the stage of the disease. So staging is how much has the disease spread. So suppose there's a small tumor in the cheek, whether it's only in the cheek, whether it's involved the gums, whether it's come to the skin, whether there are nodes in the neck because of that, whether it's spread rest of the body, all these factors will decide what the stage of the disease is. So one, knowing exactly what kind of cancer it is, and secondly, knowing exactly what parts of the body it has spread to, gives us the basic framework from which we can decide about the course of the treatment. uh, so now we come to the next thing that a surgical oncologist or cancer surgeon does is deciding on what is the right treatment. In the vast majority of treatment nowadays, there are very clear guidelines. We know exactly this cancer, this type, in this stage, we need to do this. But there are still a lot of gray areas. So this part is generally a collaborative part. So a cancer surgeon with pathologists, with radiologists, with medical oncologists, radiation oncologists, any other branch such as nuclear medicine which is involved in this decision making, we sit together. We used to call this thing a tumor board, but nowadays it's called multidisciplinary team meetings. So MDTs is what we call it. So in an MDT, we decide on, say, in a breast cancer, there's a lot of ambiguity in breast cancer, whether to give chemotherapy first, what kind of surgery to do, what do we need to do about the nodes in the armpit, whether they will need radiation, whether hormone therapy, targeted therapy. There's a lot of options in these kinds of cases now, and there's not one single right answer. So depending on the patient, we sit in a team and we decide on the course of the further treatment, which is called an MDT meeting, and that is another thing that a cancer surgeon does. Then we do surgery, which is the crux of what makes us a cancer surgeon, but we'll come to that later. And then what we do is we need to convey these decisions to the patients. We need to take their consent on that. And once the treatment is done, our job is not done. We need to keep following up the patients. We need to keep uh, screening them for recurrence of the same cancer and sometimes for any other cancer which is likely to happen in that patient. And this goes on for several years intermittently. And lastly, there's one part which sadly a lot of people overlook. Like in India, we say a marriage is not just between two people, it's between two families. Cancer is also a disease which doesn't affect one individual, it affects a family. So we need to look at the entire family. We need to take care of the entire family, their emotional, their uh, physical needs, their even their social and economic concerns need to be addressed. Oftentimes, it's the family members who start falling sick once uh, cancer uh, the cancer patient starts to revive. So this all is the spectrum of cancer surgeon, and it's a wide spectrum, much broader than most specialties, especially most surgical specialties, and that is one of the big challenges of being a cancer surgeon.